Hello, welcome to the Psychiatric Grand Rounds for today. Sorry for the little bit of a delay. We are still in the process of waiting on a nurse to bring down a bottle of water from the clinic, which I didn't realize would take so long. And I do want to welcome you all back. And if we have any new people watching after Psychiatry in the Mountains last week, because I know there were a few people there that were informed of the Grand Rounds and maybe tuning in today. But thanks for being here. We had a really great presentation we're looking forward to from the new chair of the Department of Psychiatry and Behavioral Sciences here at East Tennessee State University, Dr. Karl Goodkin. I don't know if there is an introduction that I can give that would do him justice, but just some highlights on his very extensive resume include obtaining his both medical degree and Ph.D. in clinical psychology from the University of Miami, completing his psychiatric residency at Stanford University, and he is joining us where he was the Administrative Director of Mental Health and Services and Research for the AIDS Healthcare Foundation, which is the largest primary care provider for HIV-infected patients in the U.S. with clinics in California, Florida, Washington, D.C., and 22 countries. As I know we're a little bit late getting started, I'm going to go chase down the water and let Dr. Goodkin go ahead and get started. If you'll help me in welcoming.
Thank you very much, Jeremiah. So I'm going to speak to you today about an overview of psychiatric issues in HIV/AIDS, and we're going to do what I would consider brushing the treetops of different areas, hopefully to whet your appetite to know more about each of the areas. My own experience in HIV goes back to the early days in the epidemic. Saw my first patient in 1983. So I go back all the way to the days before AZT was approved, and essentially the diagnosis was a death sentence. So we certainly come a long way, thank you, Jeremiah, from that. Well, here you can see a global representation of the frequency of HIV with the world map representing proportion of cases and predominant number in sub-Saharan Africa, 2/3. Large number of cases also in India and Southeast Asia. And as you can see, in Western Europe and the US, quite a bit fewer cases. And yet, most of our research, I'm sure you would guess, comes from Western Europe and the US, where it is relevant, not just from the point of view that there's, of course, very different demographies, but also HIV itself is different, because the subtype of HIV that's most common in the US and Western Europe is clade B, and in sub-Saharan Africa and in India, much more commonly clade C, which relates to neuropathogenesis as well. Let's talk a minute about the virus itself. And HIV is a retrovirus, so its core is RNA. And it also has core proteins. P24 used to be a way that we would quantify the activity of HIV before we had viral load measures where we could quantify the amount of HIV RNA per mil of plasma that we commonly use today as a measure of disease progression and control by therapy. Also important in terms of the virus and toxicity is its glycoprotein code, specifically GP120, which is associated with neurotoxicity, as well as a regulatory protein not depicted here called TAT. And there are several enzymes of importance in the virus's activity that I'll be talking with you about here as well. And so, talking about the life cycle of HIV, thinking of this as the CD4 cell and a whole virus approaching the cell, you have initially binding and then penetration of a virus into the cell, uncoding, reverse transcription of HIV RNA into complementary DNA, which translocates as a complex into the nucleus, where the HIV proviral DNA can be integrated with our host cell genome and become latent or circularized in the cytoplasm. And over time, multiple different activators of transcription can cause transcription to occur with messenger RNA produced, and then translation of that messenger RNA into viral proteins in the cytoplasm, with ultimately packaging of these viral proteins into whole virions and budding of the virion off of the cell. In the case of the CD4 cell killing the cell, and that's in fact the ontogeny of immunopathogenesis of HIV, with subsequent decrements in CD4 cell number over time, which was one of our early ways of demarcating the progression of HIV infection. So there are several enzymes that we are able to inhibit the virus. One of those is RT, reverse transcriptase. And zidovudine, AZT, was the first of those drugs. There's a whole group, as you can see, there now represented. The protease inhibitors acting at the opposite end of the replicatory cycle late in terms of preventing the clipping of proviral proteins into their final forms before packaging. Entry inhibitors, currently most commonly used as Maraviroc, a CCR5 antagonist, which is a chemokine co-receptor of the virus, predominantly on monocytes and macrophages. Integrase inhibitors, important relatively new class that inhibits the integration of complementary DNA into the host cell genome. And finally, maturation inhibitors, actually these are only in development, no FDA approved members of that class currently. So just a little bit more about the course of HIV infection itself. Untreated, initially you have very high levels of viral load, and then in the asymptomatic phase, which can go on untreated for 12 years or more, you may have a very low level of plasma viral load at a set point that's established that can be variable. But ultimately, it will increase to a very high level again, as it is in acute infection. And that will demarcate the period in which AIDS defining conditions occur. The CD4 cells show the opposite kind of trajectory. And so we start out with a normal CD4 cell count, but slowly and surely over time, even in the asymptomatic phase, there will be a drop-off of the number of these cells, and ultimately in AIDS to a very low number, associated again with the development of clinical AIDS-defining conditions. The killer T cells are actually here referring to CD8 cells that are cytotoxic for HIV, not natural killer cells. And these cells become sensitized to HIV very early on and effective in killing HIV for a long period of time until ultimately they become exhausted or senescent and drop off in disease progression. Just to give you a little bit of a feeling for the way that we look at in terms of laboratory changes over time, HIV disease progression. So now we're going to switch our focus to the psychiatric disorders occurring in the context of this long-term infection. And today we'll be covering the disease categories of anxiety disorder, depressive disorders, hand or HIV-associated neurocognitive disorder, substance use disorder, and psychotic symptoms. And we're going to have to exclude a number there at the bottom that you can see, just to try to cover these bases. Now, early on in the epidemic, this is an old slide from CDC, looking at progression of HIV. AIDS was the tip of the iceberg, and then you had non-AIDS defining conditions just below that, formerly called ARC. I don't know even how many of you here in the room have ever heard the term ARC, or AIDS-related complex. And back at the base, asymptomatic infections. Now, why am I showing that to you? Well, it turns out that psychiatric disorders in HIV, in terms of their frequency, recapitulate the systemic progression of HIV. And so most commonly, in early HIV infection, in the asymptomatic stage, we see anxiety disorders, very commonly related to the diagnosis itself. Depressive spectrum disorders tend to come later after the asymptomatic stage when a patient gets first symptoms of HIV. And finally, neurocognitive disorders are most prominent in the late symptomatic stage, or AIDS. So there you have it in terms of the psychiatric parallel pyramid. So let's talk about anxiety disorders. Well, adjustment disorder is the one that's most frequently seen, and this is related to serostatus notification. So normally, of course, you would expect that people will become anxious after being notified of being HIV positive, and a number of studies have shown that that anxiety typically resolves within about 6 weeks. Once that anxiety starts persisting for a longer period of time and interfering with functioning, it then becomes in the region that we would be starting to be concerned about for making the diagnosis of adjustment disorder. And then if, as it does apparently do in about 20% of patients, the anxiety not only persists but becomes more generalized outside of issues relating to having the diagnosis made, generalized anxiety disorder, GAD, may be diagnosed. And in studies in prevalence of psychiatric disorder in HIV, GAD has been found in 15.8% of those with HIV compared to 2.1% of the general population, to illustrate that. Panic disorder is also more common in HIV, and many of you may know is associated with viral infections generally. Been noted in 10.5% of HIV positive individuals versus 2.5% of the general population. PTSD has also been reported in an elevated rate amongst the HIV infected, but in terms of PTSD, the relative differences have a lot to do with the history of the particular group being studied, and their early trauma history and exposure to trauma as adults. And in many studies, it's been suggested that women are particularly more likely to have higher rates of PTSD related to histories of physical and sexual abuse that also are likely to be related to their lack of ability to negotiate risk-taking precautions in sexual relations that would be likely to be associated with them contracting HIV. So what do we do about the anxiety disorders in HIV infection? I think the most important thing to say, especially for psychiatrists, is not to immediately reflexively give medication for anxiety disorder. It is important when the anxiety is so high initially that you need to bring it down to control it, to give the patient some sense of control and autonomy, but not to be thought of as the primary modality. Of course, the most common anxiolytics used are the benzos, and the benzodiazepines are sedating, interact with alcohol, foster dependence, and importantly, in terms of HIV-related drug interactions with the antiretrovirals, they are metabolized on a cytochrome P450-3A4 isoenzyme system, which is in common with the protease inhibitors of HIV, and therefore is a concern in that regard for their use as well. So we prefer to use non-pharmacologic means, supportive therapy, cognitive behavioral therapy, progressive muscular relaxation training, cognitive imagery, biofeedback. All of these can be used. If pharmacotherapy is necessary, we like to use the SSRIs, venlafaxine being a good example of one that doesn't have an issue with drug interactions, rather than the benzo group. But if we're needing to go to the benzodiazepines for immediate control of anxiety, we like to use those that have no active metabolites and are simply glucuronidated in the liver, like lorazepam and oxazepam, for first choice. Buspirone is an option that I've used frequently, and if explained properly in terms of delay of onset, can be very effective without the other concerns about side effects of the benzodiazepines to worry about. Hydroxyzine and diphenhydramine I've certainly used effectively, and especially in patients with substance use disorder, where I'm trying, again, to avoid the benzodiazepines even more likely. It's a good potential choice, and many of these patients are not benzodiazepine naive, so buspirone typically doesn't go over as well. But hydroxyzine and diphenhydramine are relatively well tolerated and effective in this patient group. And there is some evidence for pregabalin being effective for GAD as well. So let's turn now to depression. Depression is in terms of a group of disorders. That's why I call it depressive spectrum disorders. We're not just talking about major depressive disorder, but we're talking about dysthymic disorder, adjustment disorder with depressed mood, the depressive episode in a bipolar patient, all of these depressive disorders. And depression generally, in terms of this context, has been found to occur in the majority of HIV-infected patients over time. In my work at AHF, we actually showed that over 80% of patients over 2 years had 2 of 4 marker screening questions for MDD that were positive. So this is a major concern still in HIV today. It is not a bygone worry of the past, as many people seem to think that it is. And also, let me tell you, even in the US, HIV itself, in terms of the progression of the epidemic, is by no means a bygone worry. We're getting 56,000 new cases a year in the US, despite CDC's efforts every year to curtail that figure, and a lot of funding aimed at doing that. So this epidemic is by no means under control, not only internationally, but nationally. So what happens with depressive spectrum disorders relatively commonly is that when the patient, as I was suggesting earlier when we were talking about the spectrum of psychiatric disorders matching systemic disease progression, when that patient who's been asymptomatic for years and has many times gotten used to thinking that I'm never going to progress. If I keep doing everything really well, taking my antiretrovirals exactly, on time, being fully adherent, and by the way, we need 95% adherence to these regimens to get non-detectable levels sustained chronically. So that's a really tall order, as you can imagine, for people to do for the rest of their lives, at least as now, that we currently know that it still looks like we need lifelong therapy. We're trying to aim at changing that, but right now we don't have the capacity to do so. We're talking about lifelong therapy, 95% adherence for maximal control. So even if you're not highly stressed by having HIV infection, that's a tall order for the average person. In the general population, just to give you an example, 80% adherence for an prophylactic antibiotic regimen before a dental procedure is considered good, quote unquote, adherence. So 95% for the rest of your life, I think you have to think of it as exquisitely good adherence. Okay, so this patient who's been living asymptomatic for years, who's getting used to the idea, gee, I really can control this, you know, maybe I'll never get disease progression, gets a symptom due to HIV. What happens? Well, it's not just a diagnosis of the disease related to that symptom, but it's the psychological response to that diagnosis, which many times is devastating in terms of that patient's cognitive development of their view of their own disease progression. Because that's when the bubble gets punctured. That, hey, maybe I'll never get a symptom. I'll just be fine. I'll be living a normal life. My functional status will be fine. You know, I'll look like Magic Johnson, who's basically been a poster person for the antiretrovirals and how effective they can possibly be, and I'll never have to worry about it. And as you can imagine, when that bubble gets punctured, what is associated with that is depressed mood. And in that context, not only is it depression at the initial period of first being diagnosed, but the other thing that happens is, what's my cognitive perception toward the future now that I've had a symptom, with HIV being the explanation for it. When am I going to get full-blown AIDS? And that has been described to me by many patients as like walking through a canyon where there's this boulder way above you that's following you, and no matter what you do to try to get away from it, it's still there and it can drop on your head at any time. And that boulder is the AIDS diagnosis. That uncertainty is associated with depression too. So it's not just that initial bubble bursting of getting that first symptom, but it's what happens later that continues to lead you to have a disposition to depression in that whole period. And I should mention that earlier on in psychiatric disorder research in HIV, it was thought that, well, maybe there's really no true increase in MDD in HIV. It might just be that the risk groups had higher rates of MDD than the general population. That has now been put aside as an explanation. Subsequent research has shown that there is a clear relationship to onset of symptoms, as I'm discussing with you, and the occurrence of depressive disorders. And along with that, suicidal ideation not uncommonly in HIV. Even in the era of effective art, as we now call it, highly active antiretroviral therapy, many of you may be more familiar with the term HAART, which became used in late '95 when the first protease inhibitor, sequinavir, was approved. And you had the potential to use two nucleoside RT inhibitors and a PI together to get full suppression of viral load. The PI has really made a huge impact in our ability to curtail the morbidity and mortality from the virus that led to the development of the term highly active antiretroviral therapy. However, we have now changed that use of the term to effective antiretroviral therapy. You'll also hear combination antiretroviral therapy, or CART, because we now know it's not as highly effective as we had hoped in late '95. Okay, so we still have depressive disorders at a high rate with suicidal ideation, in fact. Elevated physical symptom burden, pain level, substance use are all concerns in this setting, and the physical symptom burden not only contributes to depression, as you would expect, but also to increased likelihood of substance use, and the pain level can further contribute to increased likelihood of substance use, and one of our current major concerns in substance use, prescribed substance abuse and dependence. So things get very complicated, as you can see rapidly, in looking at HIV-related psychiatric disorders as symptoms develop. It's not just depression, certainly, that's a concern. And the patient has to learn a way to adjust to this long-term uncertainty that I was talking about when the boulder of the AIDS diagnosis might drop, which is a tall psychological order for patients to be able to complete, and a good number of them don't do so or need significant amount of help, support, therapy to do so. What's the differential diagnosis of depressive disorders in HIV? Well, we know that we have to look for HIV wasting syndrome, not nearly as common these days with effective ART as it used to be. And early HIV-associated dementia, or HAD, formerly AIDS dementia complex. Early HAD can present with apathy, lethargy, and social withdrawal and look just like depression, but not be. And more commonly, you won't see as much in terms of the cognitive symptoms of depression or the primary affective symptoms of depression in early HAD, if that's what the disorder causing this symptoms that might appear to be depression is. Toxicity of medication in terms of depression, interferon alpha, particularly well known in this context, and many of you may know that interferon alpha has been a primary treatment for hepatitis C virus co-infection, very common amongst injecting drug users. Though I should mention that HCV treatment has even more rapidly progressed than HIV treatment, to the point that there's almost an 80% cure, true cure rate of HCV. And of course, we can't cure HIV. Along with that, the progression of the use of the HCV protease inhibitors has gone to the point that we're going to be looking at interferon alpha HCV treatment in the very near future as a standard. So, in terms of treating depressive spectrum disorders, we can use the same antidepressant medications that we normally would use outside of HIV infection. They're just as effective. That was a question early on. They don't have negative immune implications. Certainly, there is some evidence that they might have positive immune effects. We can talk about that. I'm going to lead a little bit into that area. Important considerations are side effect profiles, potential for drug interactions, again, just like is true for the benzodiazepines, and the neuroinflammatory impact of MDD itself. So major depression is associated with increased pro-inflammatory cytokine release, tumor necrosis factor alpha, IL-1, and IL-6, related to HPA axis stimulation. Well, guess what? HIV causes pro-inflammatory cytokine release. Not only that, but we know that even if we suppress viral load to non-detectable, the pro-inflammatory cytokine release associated with HIV and the inflammation goes on and causes morbidity and earlier mortality that we still see even with patients well controlled. So this is very clinically significant. Of interest is that there is some research suggesting that inflammatory markers in the peripheral blood might be possible to use to identify suicide risk and MDD risk and treatment response. So there's a lot of progress being made in this area. One very interesting area of research recently presented by Hammond et al. Of the Charter study, one of the multi-site long-term studies looking at progression of HIV in the era of effective ART, has looked at CSF viral load, controlling for multiple other factors, and has found that elevated CSF viral load predicted significantly subsequent major depressive episodes, controlling for history of major depression and other important control variables. So this relates to the importance, potentially, of the overlap of major depression and HIV in terms of neuroinflammatory profile. That is, it may be important to control major depression to prevent progression of disease, both systemically and in the CNS. And here you can see the adjusted odds ratio, hazard ratio for the elevation of CSF viral load on occurrence of episodes of major depression in that study. So when we choose antidepressants, we're concerned about choosing those that don't interact with the antiretrovirals, and I mentioned venlafaxine is a good choice. Paroxetine has been favored amongst the SSRIs, as well as citalopram. Fluoxetine should be avoided, we feel, because of its long half-life and due to its metabolism on both 2D6 and 3A4, which would make it more likely to interact with the antiretrovirals. Bupropion, we do consider using this medication. Certainly, it's an alternative of interest when, for example, we have meth use in a patient who's trying to abstain. Bupropion has been shown to be a useful medication in this setting. In addition, if you are having problems with a patient who has sexual side effects of the SSRIs, bupropion may be a good choice, but you have to be aware that bupropion is associated with a seizure diathesis. HIV itself is associated with a seizure diathesis. So when you go over 300 milligrams a day, you're in an area of greater concern for the use of that medication, although we certainly do use it. Okay, let's shift now to talking about the disorder that occurs most commonly at the end of disease progression in full-blown AIDS, HIV-associated neurocognitive disorders, or HAND. Now, while I say that it occurs most commonly in the end, that by no means is an exclusion of it occurring earlier. So you should be aware that it occurs in all stages. It's just most common at the end. And of great importance in the nomenclature of these disorders and defining them accurately was the Frascati Conference that revised the AN's 1991 criteria for diagnosing the former disorders to MCMD and ADC that were originally denoted. Now we refer to them as mild neurocognitive disorder of MND and HAD, HIV-associated dementia. And we've added a third term for asymptomatic neurocognitive impairment, or ANI. And that, as a group, is what defines the term HAND. ANI, MND, and HAD in order of severity. And I had the pleasure, actually, of serving on this group that developed the consensus for making these diagnoses. End of 2007, they were published. And I should mention HAND is a global problem. And here you can see that the rates in different countries around the world are relatively high. And I contributed this study from Buenos Aires. But there is variance. And some of that, we think, relates to clade variation that I mentioned early in the lecture today. So how do we diagnose these disorders? For a diagnosis of mild neurocognitive disorder, or MND, we need decrements of neurocognitive performance in at least 2 domains that would be expected to be 1 to 2 SDs below norms, and at least minor impairment in functional status in activities of daily living with no other known etiology for the symptoms. And that, by the way, is very important in HAND diagnosis because we can find multiple causes for cognitive deficit in HIV-infected patients. Here is actually a patient who had MND in a study that I was conducting using MR spectroscopy to try to define MND better than would normally be allowed by neurocognitive testing and functional status alone. And so we did an MRI and FLAIR imaging in this patient, and you can see periventricular hyperintensities, which are common in HIV-associated neurocognitive disorder, though by no means pathognomonic. In this same patient, we did the MR spectroscopy, and I'm showing you this as a template to understand the spectrum I'm about to show you from this patient. But the markers that we use from MR spectroscopy to look at absolute concentrations of metabolites in brain regions, so we can be regionally specific with this non-invasive technique to get signatures of different CNS disease, includes several that are depicted here, including NAA and N-acetylaspartate, which is a marker of neuronal cell death, GLX is actually a combination of glutamate and glutamine associated with excitotoxicity that was of special interest to us in this study. Choline, marker of membrane turnover, and myoinositol, a marker of microglial proliferation. And in this particular patient, in the basal ganglia, we found, and I hope you might be able to appreciate this from the prior slide, kind of a bunching of this peak here with the NAA peak coming down and the GLX going up. That's a sign of hand. For a diagnosis of dementia, there should be severe cognitive impairment, at least 2 SDs below norms in 2 or more domains, and at least moderate functional status impairment with, per DSM criteria, no evidence for delirium and no support for another etiology. And then we have ANI. Very important to understand and many times overlooked is that ANI is not a disorder, it's a condition. And why do I say that? Well, when people used summary markers of total number of hand cases, they're including ANI in these figures. So you're getting these 40 to 50% figures that are including ANI. But in reality, patients with ANI only have testable impairment and no decrement in functional status whatsoever. The patient, him or herself, and no one else would know from interacting with the patient in any way, even intensely on a day-to-day basis, that they had any kind of impairment. So it's difficult to say that that's a disorder, right? And in fact, from DSM point of view of requiring functional status decline as a demarcator, it's not. ANI, very importantly, has not declined in the era of effective art. Why is that? When all of the other AIDS-defining conditions have declined, why would hand, particularly ANI, but inclusive of MND and HAD, not have declined as much as a group? The reason is that the CNS is a reservoir for HIV replication. In the setting of controlled viral replication in the periphery, non-detectable levels, you can have elevated levels in the CSF for a number of different reasons, which includes resistance and something we refer to as CSF escape. Okay, so what's actually happened in the era of effective art with hand is that the severity has decreased. We've seen a huge decrease in the number of dementia cases by more than 50% from the old days. We've also seen a parallel decrease in mild neurocognitive disorder, but ANI not. And ANI remains as a substrate, therefore, for the recrudescence of neurocognitive disorder in HIV should we fail at any point to maintain the development of antiretrovirals at the pace that they have now been, and should we fail to maintain control over resistance to the antiretrovirals. Now, some of you may say, oh, well, who's worried about that? I'm worried about it. One reason I'm worried about it is that we have PrEP out there, pre-exposure prophylaxis. That means that anybody who wants to get an antiretroviral to prevent getting HIV can just ask their doc. Well, what happens when everybody's using that? Resistance, just like general antibiotic resistance we worry about, right, in primary medical care. The antiretrovirals will actually become, believe it or not, the same way. And that could be a real problem if we have ANI maintained at the rates we do and have it be able to recrudesce into MND and HAD in the future. Here's a study that I did on older age neurocognitive impairment, and many of you may be aware that we're about to cross over next year into having 50% or more of patients in the US be over 50 years of age with HIV. When I first started studying this in the late 90s, I submitted a grant to NIH, and they said, that's a very interesting concept, Dr. Goodkin, but there aren't enough older patients with HIV to study anyway, so maybe we better wait on this. Well, the definite response now is we better not wait any longer because we're way out of the box on this problem. And this will follow worldwide. We're leading along with Western Europe, as you would expect, because part of the reason for this problem is the success of antiretroviral therapy and the aging of the infected patient population due to the success of antiretroviral therapy. Let me also mention to you, though, that's not the only reason. Older people get newly infected, too. And you have to do your sexual history and drug abuse history with people over 50, not just people who are younger. Well, in this study, I used the multi-center AIDS cohort study database. Now, many of you may know that the MAX is the longest term multi-site study of HIV epidemiology in the US, goes back to the early 80s. So I had a huge database available with a total of 47,000 plus visits we analyzed and 5,000 plus participants. And for HIV positive participants, 20,000 plus visits and over 2,000 participants. For negative participants, we had high 2,000 range and 27,000 plus visits. We used as our predictors theoretically for age as a continuous variable, HIV disease stage. A, B, and C means asymptomatic, early symptomatic, and AIDS, with HIV negative as 0, and the interaction. And we were particularly interested in the interaction because we believe that older age and HIV have a synergy, and they don't just add independently. This is a big question now because most of the research has suggested to date that perhaps they just add independently and there's no true synergy of the two. So my study was directed at that question. We looked at using multiple covariates. You can see them here. We were able to do all of these because of the extensive MAX database and use statistical analysis by linear mixed models. And we found, to cut to the quick, that 2 domains were synergistically impaired with these controls and the addition of one very important one. And that one is actually infection duration. And it was the MAX that allowed us to control that, because most people have no idea what their duration of HIV infection is. And we don't use as a proxy for that, by the way, a date of antibody testing positive, because that can be years away from the actual time that someone contracted HIV. But in the MAX, when they were followed longitudinally every 6 months, we could get a pretty good estimate, a large number of patients, of seroconversion and use those participants in this analysis. And we found that when we included that control, we did see these synergistic effects in the 2 domains of episodic memory and motor function. Whereas when you did not use that control, you did not see that, and it looked as if they were totally independent, like some of the rest of the research shows. So we think that infection duration is a very important control variable that needs to be looked at more in the future in this area. How do we screen for the neurocognitive disorders in HIV? Well, the HIV dementia scale, a number of you may be familiar with, was developed specifically for that, but dates back to the mid-90s. Now, HAND has actually changed significantly since that time. So some people suggest that the Montreal Cognitive Assessment, or MoCA, might be a better screening test now because it includes both cortical and subcortical deficits, and HDS is predominantly focused on subcortical, as the early manifestations were. However, the data today don't actually support that, so I think that's equivocal. But it's clear that they're both better than the mini-mental status exam, and I would strongly suggest to you not to screen with the mini-mental. If there are cultural issues, and this is within the US, I suggested the International HIV Dementia Scale be used, the IHDS. Many times Hispanics, for example, won't respond the same way to the items on the HDS that will be based on writing the alphabet quickly, because the alphabet's different in Spanish, and copying a cube, because neurodevelopmentally, Hispanics generally acquire that function later than we do in the US. So right here in the US, we should use the IHDS, I suggest. But certainly internationally, it's been shown to be effective in culture fair and have a good rate of identifying hand. This is, though, just the beginning. When you do the screening test, that's the beginning of the workup. Ultimately, we'd like to get all patients neurocognitively tested thoroughly by a neuropsychologist. We can't always do that. So if we can't, we go on to other aspects of the workup. That includes functional status assessment, preferably quantitative, and exclusion of other illnesses with CT or MRI of the head. And this is particularly useful for toxo. And as well as primary CNS lymphoma. And LP, particularly useful for cryptococcal meningitis, but also for a number of other conditions which we can use specific PCR techniques to pick up, like CMV encephalopathy and PML, though rare, lethal, caused by JC. You also have to do a workup for metabolic causes of encephalopathy and psychoneurotoxicity of prescribed meds and substances of abuse, not to mention your psychiatric workup and, for example, making sure major depression isn't causing the cognitive impairment. So what do we do about hand? How do we treat it? Well, CSF penetrating antiretrovirals are the best answer to that, but they're limited in number to a few that get into the CNS very well. And here you can see actually a ranking of penetration effectiveness developed by Scott Latender at the HNRC of UCSD. And you can see those higher penetrating drugs listed here. But there are a group of relatively higher penetrating drugs that are useful. And we now are looking at intensifying normally used regimens with 3 drugs to add 1 to 4 with maraviroc and raltegravir, which get into the CNS pretty well in terms of fusion entry inhibitors. And I mentioned CCR5 antagonism by maraviroc, CCR5 being important because monocyte carries HIV infection past an intact blood-brain barrier initially into brain. That's how HIV gets into brain, through the monocyte, not through the lymphocyte. And CCR5 is specific for monocytes. Raltegravir being an integrase inhibitor, decreasing potentially latent infection, and latent infection we think is relatively more of a concern in CNS due to the fact that it's a reservoir. Neurotransmitter manipulation is also very important, and while NMDA receptor antagonists have not proven to be, unfortunately, very effective in hand specifically. Looking at increasing dopaminergic transmission seems to be well supported, and the psychostimulants for quite a bit of time have been used. No definitive clinical trials, I have to say, still, even though multiple studies have been done suggesting they're effective. So I think that's important. DA agonists may also be effective. In terms of using the psychostimulants, we have some cautions in their use. Substance use, of course, being one of those. Late HAD, another one, whenever there's psychotic symptoms presence, that is a concern. And then avoiding disposition towards seizures when there's history of seizures or CNSOIs. Substance use disorder in HIV. And I'm going to have to move a little quickly here to try to finish up. But substance use disorder, as you would guess, is a major concern in HIV because this is a source of contracting HIV originally. And the number with IV drug use history, 24% originally shown in this study from 2001, is not nearly as high currently. It's 12%, but this is still a significant group to be concerned about. But note that 46% reported some history of drug use, and this is the larger part of the iceberg underneath IV drug use that we have to be concerned about in terms of substance use disorder in HIV. associated with substance use disorder is lower odds of receiving effective ART. Partly because the docs are concerned about prescribing them because they don't think the patients will take it and then we'll get more resistance. Just to give you a feel of the difference from the general population, 9.4% of the general population report current substance use, 32.5% in terms of HIV-infected patients reporting current substance use. So that's over 3 times difference. And veterans with HIV being studied quite a bit more these days, especially with the concern about older age and HIV in Amy Justice's study called the VAX, Veterans Aging Cohort Study. And there they looked at alcohol use, which has been frequently passed aside as a concern and is a very significant concern in terms of hand prevalence. And I think that we will see more research looking at this, not just in VA populations by any means, where some people assume that, well, it's a greater concern there. It's definitely a concern in the general population as well. Well, when you have substance use in HIV, another thing you can anticipate you're going to have very likely is depression. And this study looked at just that, with substance use and HIV, finding that major depression occurred in 73%. Well, what about if you add to substance use and HIV, HCV? We know that HCV is very similar in terms of the likelihood of depression presenting over periods of time, even without interferon alpha treatment. And so we could be looking at a quadruple diagnosis issue, not just, we talk a lot about dual, and you might think about HIV substance use and depression as triple. Well, with HCV, maybe it's quadruple. Major concerns. What about substance use and HIV in terms of treatment? People with substance use disorders receive ART less frequently get their viral load tested, have poor adherence to ART, and receive lipid screening less frequently, which we're very concerned about now with people living longer and succumbing to MI and CVA in the long term. More likely to get symptoms, hospitalized, decreased quality of life, decreased survival time. And multiple other things associated with substance use in general. So cognitive impairment itself being associated with substance use, violence, family and social disruption, criminal activity, neurotoxicity in terms of different substance use being different in that regard, but meth being very high in neurotoxicity and a major concern in frequency of substance use. And in fact, increased community viral load and likelihood of disease progression being increased in the general population. Community viral load, by the way, is an indicator epidemiologically we use of likelihood of disease spread, just in case some of you haven't heard that term. So we want to screen actively for substance use and treat actively, much more than is the case, unfortunately, currently. And I want to end with psychosis. I realize we're at the end of our time, too. And that's unfortunate because I found that there's still a low sensitivity to psychotic symptoms in HIV out there. Many of the primary HIV docs I work with say, what psychotic symptoms? I don't see that. But in reality, they're there and they're being overlooked, believe it or not. People with severe mental illness in general are at increased risk for HIV. Fran Kornos has shown this. There's a range of studies in different populations showing an increased risk from anywhere from 4 to 23%. So this brings it into the home of the primary practicing psychiatrist, because just having a psychotic disorder makes you at increased risk for HIV. So psychosis, of course, can be an antecedent of HIV disease, but it can also occur in consequence to HIV disease, and it can occur in acute HIV infection. It also can occur in later stages of HIV, and there it typically manifests as a mania. And the mania is generally, you'll see these symptoms typical of what we expect with manic symptoms, except for the fact that we also find cognitive impairment relatively prominent in this setting. So we need to look at other possibilities, of course, for mania 2 listed here. And by the way, zidovudine and or AZT and efavirenz can be associated with mania. Cryptococcal meningitis, neurosyphilis can also be associated with mania. Primary treatment for mania and HIV, valproic acid has been considered to be a top choice, but lamotrigine is also a very good choice. And it looks like my, oops. Losing my, okay, thank you. Lamotrigine is also a very good choice. And the reason that valproic acid was considered number 1 was because it also was associated with decreased mania-associated cognitive impairment that I alluded to. Of course, you have to monitor liver functions more actively with the use of valproic acid. What about the use of the antipsychotics? Well, this is very important to be aware of. In delirium, it's been suggested that low-dose haloperidol is a good choice, and that's by an older study already now of Bill Breitbart. But we also know that with the typical antipsychotics, we need to avoid both anticholinergic side effects of the low-potency drugs, memory impairment associated with those, and EPS with the high-potency drugs. And in fact, use of the typical antipsychotics can uncover subclinical dyskinesias caused by HIV that don't revert to normal after DC of the drug. So you do have to be very careful about this. As a result, atypicals have become the drug of choice, but the atypicals don't get you totally out of the concerns either because of metabolic side effects of the atypicals, and because the antiretrovirals themselves have metabolic side effects, most particularly the PIs, the protease inhibitors. So you have to try to choose the atypicals with the least likelihood of metabolic side effects, aripiprazole and ziprasidone being good choices there. And with that, I'll close. I'm already a little over. Sorry about that, folks. For any of those who can stay, I'm happy to take questions. Yes?
When addressing insomnia in this group?
Great question. Are there special considerations for addressing insomnia? And remember, I mentioned at the beginning there were some things I was not going to be able to cover. And insomnia, sleep disorders was one of those, very common in this patient population. Major concern, partly induced by the antiretrovirals themselves. So yes, definitely. So one issue is looking at whether or not the antiretroviral might be causing the insomnia. Primary effect of efavirenz in terms of neurotoxicity is insomnia, related to very vivid dreams. And I actually participated in an ACTG study that demonstrated that. So it's a common reason for discontinuing efavirenz. And by the way, efavirenz, amongst all the antiretrovirals, has the highest rate of psychiatric side effects, 50+%. That's high. Other issues with insomnia is it's similar with anxiety. You don't want to use hypnotics if you can avoid it. You want to use means of manipulating patients' sleep hygiene to the maximum first before you start using the hypnotics. Once you start with the hypnotics, you may not be able to come back from their use, and that's a real problem.
Any experience with or insight into the idea of using neurostimulatory techniques with hand and depression, ECT, or TMS, either of those?
Yeah, so the question is, what about using neurostimulatory techniques in hand from Dr. Hendrick? And that has not been well investigated. Early on, ECT was thought perhaps to be contraindicated in HIV. That's no longer felt to be the case. So that's one important thing to know. No good studies of TMS that I'm aware of. Yes?
Towards the end, you talked about valproic acid and its use in treating mania. And I was just wondering if you could talk a little about its use in shedding, helping shed the virus, or do you have any treatment for that? Shedding the virus from like
Well, that's okay. So, a question, well-informed question from the back here about valproic acid. What about other issues in use of valproic acid in terms of HIV infection control itself, rather than its use just to treat mania and look at response in mania? And this is an interesting area because early on when valproic acid was being looked at, the concern was that it increased viral load. And there was an in vitro study suggesting that it did that. However, that was not confirmed subsequently in vivo. So there was less concern about using it after that. But now things are switching to the opposite end of, not in terms of looking at shedding, but looking at valproic acid as a GSK3 beta inhibitor. And as a result, potentially an anti-neurodegenerative that can be treating cognitive impairment in HIV. And there's some preliminary work that suggests, in fact, that it's effective. Interesting, along with lithium in that regard. Lithium we normally have avoided in HIV because of the spectrum of side effects and neurotoxicity. Yes, Dr. Moore.
I was interested in the invasive techniques like spinal taps that you commented on. Is there any evidence to say that technicians and other medical people are any more likely to be getting infected with HIV with that kind of procedure? Is there any evidence that we still should be very careful about handling those kinds of things?
So the question was, in talking about using LPs in doing a complete diagnosis of hand, how much do we need to be concerned about HIV transmission occupationally in that setting? Well, we always have to be concerned about HIV transmission occupationally. I can't overemphasize universal precautions. Patients who have HIV are not the only patients that we are talking about in this setting. Anyone who gets an LP, not somebody who's just getting a workup for hand, are who we are talking about, because approximately 25% of patients with HIV nationally don't know they have HIV, and neither do we. So we better be using universal precautions in doing LP. And I'm sure that many of you know that of current interest, maybe even greater than HIV in this regard, is Ebola. So we need to be aware of concerns about spread of virus that involve contact with body fluid, and exquisitely concerned about it in settings where there's a guaranteed occupational exposure and the potential for the contact with those body fluids, right? And then when there might have been a contact, reporting that contact as an incident and following through with the post-exposure prophylaxis. By the way, if you get post-exposure treatment for HIV, you are nearly 100%, as close as we can tell, protected. So the major problem is people denying it, not wanting to report it, saying, I'll be fine, and then boom. So I don't think I can overemphasize how important that is. Any other questions? If not, thank you all for your attention.